Hello, this is your brain on drugs, and this is the punk rock psychiatrist. So gonna do another updates episode today. I was trying to throw these on as bonuses on like Saturdays, but it's just too much to make two episodes in 1 week. So when I do these, I'm gonna put these in the regular Wednesday slot. And today will be our February 2026 updates. Um, it's the 6th of February, so this is all the updates that I've gotten since our last update until today. So let's kind of go through these. These are just little quick bonuses of some news that's coming out related to psychiatric medications that I think that you would find interesting. And so first, let's talk about TMS. So um, back in the depression episode, I talked about TMS. If you want to hear about TMS, go back and listen to that episode. But the Saint TMS protocol, I just wanted to let you know that they have changed the name from SAINT Saint TMS to SNT TMS. I don't know if it's still pronounced Saint or not. I guess they didn't want the religious connotation there. So just so you're aware, if you see SNT, that is the same thing as SAINT. In addition, in the world of TMS, so the Saint protocol was this newer TMS protocol that used functional MRI imaging to target centers of the brain better than the older TMS, and was also an accelerated version that worked quicker, and you had more sessions. You have tons of sessions in like one day over a shorter period of time, so that folks don't have to come every day for one session, which is kind of how TMS typically works. They come for long days for shorter periods of time. They get better quicker, and then they can also return to normal activities, work, etc., faster. But the Saint machine is really expensive, and so there's some new accelerated protocols that have come out called accelerated deep TMS. So it's a different kind of, it goes to deeper parts of the brain. Um, Swift is the name of one of these protocols by Brainway or Brainsway, something like that. And it doesn't use the MRI, but it does have an accelerated protocol, and so it's got similar results to regular TMS, but faster and cheaper than the Saint protocol. The Saint protocol has better results, but it's a specialized machine. It's expensive. Um, it's just less available, and so these new protocols kind of get us the same benefit as the old TMS, but with the accelerated benefit that the Saint protocol did, with not quite as great results, but still really good results, because TMS is pretty effective compared to some of our other treatments, medications, etc. So just letting you guys know that that's out there now. Next one, we've been talking about ADHD in the ADHD series. I mentioned one of the non-medication on the non-medication episode is a pretty popular episode. People want to know, how can they help with ADHD without using medications? And one of the things I mentioned was this trigeminal nerve stimulation system. I've never seen it. I don't have any experience with, patients using it, or does it work well or whatever. Well, a new study came out that showed that it was no better than sham treatment in treating ADHD symptoms. So if you were considering that ETNS system, I don't know what the electronic, maybe trigeminal nerve stimulation, um, you may not want to waste your time with it, because this new study showed that, I guess they did a better study on it. They came up with a better sham. I mean, it's probably got like some decent placebo, as pretty much any intervention will. And so they came up with a pretty good sham treatment, so that patients didn't know what they were getting, and it didn't outperform the sham. So not really better than placebo. So probably not worth our time. But at the same time, this is just one study, and oftentimes things will work better for some patients, but not others. And maybe on the whole, when you average everyone together, you're getting neutral results. But for some patients, it may be more effective. So And never rule it out, but I mean, it's not good information for supporting this as an option. So that that was a new study that came out. Next, so they've had all this stuff about the acetaminophen Tylenol use with pregnancy stuff, and you know, I told you that I reported on that paper before all that crazy news came out in the U.S. news, and that there were signs that there was a correlation between use and potential increases in autism, ADHD, intellectual disabilities, and so forth. But since it got like such huge press, they've done subsequent studies, and there was a new one that came out, a systematic review of high quality studies, and it showed no link between prenatal acetaminophen use and autism, ADHD, or intellectual disability in children. So whatever studies kind of saw something, and I was hearing after that, oh no, no, that's not, we shouldn't take that seriously. But now we have an even newer study that is basically saying, yep, that was like a blip in statistics, with a better review of more studies. We're not seeing any correlation or link whatsoever. So not something to be concerned about. All right. So hopefully this is like putting this to rest a little bit more. Next, so the FDA actually requested GLP-1 medications drop their suicide risk warning. All right, so this is interesting because we're going to be talking about GLP-1 medications in the obesity series. I've just wrapped up on nutrition. We're going to hit a little bit more lifestyle stuff, and then we're going to get into meds, and we're going to go deep into GLP-1 medications. And this is, I'd say, good news, right? So there was some concern when these medications were coming out that they might cause depression. And then there were some thoughts that maybe it would even treat depression. There's been some studies that have come out recently that have shown that it does not cause depression. This is, these were isolated case reports, and like more well done studies have happened. And so, with this increasing evidence, the FDA had actually originally requested they put the warning on there. And now, so it's the FDA that asked for the warning in the first place for suicide risk. And they're now basically saying, okay, I think we've cleared it. Take that off. You don't need to warn people about this anymore, because we don't even think it's a big enough deal to even talk about. These cases were probably not related to taking the medication. There weren't enough to, power the statistics enough to give that guidance. But they wanted to be cautious until they had more information. Now we have more information, and they no longer think this. This is the kind of thing that the public doesn't do well with. I always, my mom would always talk about this with the eggs. It's like, oh, eggs are good for you, they're bad for you, they're good for you, they're bad for you, and out of this confuses people. They don't they don't have the patience for how science works, right? Like, we get information, and it's like, oh man, this might be a problem because of XYZ, and then as we get more information, we might end up figuring out, oh wait, that's actually not an issue, don't worry about it. And then you can get even more information, be like, actually we found something new that actually says that you maybe should be concerned, right? So people like things to be like absolute, but like this, we don't know everything. And as time passes, we learn more information. And I don't know, it's kind of like with whenever COVID came out. um just to kind of be careful, they were saying, hey, let's be cautious with this until we get more information. Unfortunately, when we got more information, we didn't change what we were doing. That, and I think this lost a lot of trust with the public as well. It was like, hey, we took some precautions when there was a sign that we needed to do stuff, and then when we got information that what we were doing was not really providing much benefit, they just doubled down on it. And this really destroyed trust with the public. And so the flip flopping is a problem. But then, like, Here's a case where they did not flop back and lost trust because it's like, hey, you should have flopped back. And I don't know, it's kind of like you never win. It's like, oh, they don't, people don't respond to the changes, and they also don't respond to when you don't change. It's like you can't win. But I say your best case is to just is to follow the most current information we have. And so as far as GLP-1s are concerned, there are lots of risks, and we're going to talk about that when we get into those medications. But I just wanted to highlight this, that the FDA did in fact drop this suicide risk warning. All right. Um, Also, the FDA approved the first blood test for Alzheimer's disease. All right. It's the name of this test is a real mouthful. So it's a p-tau 217 um, and beta amyloid 1:42 ratio, right? So you're testing two different things in the blood, and then you're looking at the ratio. And it can, if you're on the fence about whether somebody has Alzheimer's or not, we're in early stages, we don't quite know. Um, this is a test that you could consider ordering. I think most people probably shouldn't order it, and there's always the general rule of like, if you don't know what to do with the results of a test, you probably shouldn't order the test. So, if this is something that you see a lot of, and you're thinking, man, I could really use a test to help me differentiate things. Um, I would read up on this test, right? So we've got this test now. I wouldn't just blanket order it, right? You need to go through, a proper exam and workup for Alzheimer's, and then there is a point at which ordering this test could be useful, and then you would need to know, like, okay, what am I going to do if I have the results? If you're not the kind of person that's going to necessarily know how to treat the disorder, then you probably don't need to be ordering the test, but as time passes, this test may become more and more in use, and there's other tests that are on the horizon. We're learning some more about Alzheimer's, but this is actually the first FDA approved blood test, which I think is kind of exciting. Alzheimer's, is often, it's one of those disorders that like psychiatry and neurology kind of both treat. I'd say we kind of treat different aspects of it, but it's also a big primary care one as well. So just letting you guys know about that new blood test, and you could look into that a little bit further. I haven't talked about Alzheimer's and treatments for Alzheimer's yet, but that'll be probably years down the road before I get to it. But since we have some new information here, I wanted to throw that at you. All right. So next, I've got a cohort study here. So this is a pretty big one. This must be one of those Scandinavian ones, because it's like a cohort of 4.3 million pregnancies that suggested exposure to Z drugs. So those are the sleep meds: zolpidem, zopiclone, which is not available in the U.S., and Zaloplan, right? Exposure to Z drugs in the first trimester was not associated with an increased risk of congenital malformations. Um, that doesn't mean that there aren't perhaps other risks associated with it, but 4.3 million pregnancies, that's pretty good data. So at least, we of course try to avoid use of medication in pregnancy as much as possible. But there are cases in which a patient's symptoms can be so severe that they threaten the pregnancy more than medication. And so maybe the occasional need to use a sleeping medication is out there. And now we've got some more information to kind of show that the Z drugs are not going to cause congenital malformations, which gives us some evidence that they're a little bit safer to use than maybe we thought before. I'm not necessarily recommending you use them, but I just want to give you this information. It's another piece that you can use to make your clinical decision. All right. But on that same vein, I've got another study here looking at benzodiazepine use in pregnancies, which are used for sleep as well as anxiety. And so the use in pregnancy is linked to an increased risk of abortion, preterm birth, and small for gestational age compared to non-use. And I think what makes me like both of these reports kind of came out in the last couple months, and they're very similar. You know, they're similar medications that act on the brain in a very similar way. We haven't talked about them yet. We'll go into the details. I'll probably actually get to these relatively soon. I'm probably going to talk about anxiety once I get through ADHD. But these are kind of both looking at different things, right? We're not looking at congenital malformations with benzodiazepines, and we weren't looking at abortion, preterm birth, and small for gestational age with the Z drugs. So my question would be, okay, so the Z drugs don't increase the risk of congenital malformations, but do they increase the risk of abortion, preterm birth, and small for gestational age, as this new study on benzodiazepines has shown? So, I mean, I would want to know, but so I don't know. This, we've got on one hand, Z drugs are safe in one respect, and benzodiazepines are unsafe in some other respects. So just more information, you know, to help you make the decision. It's not a you can't use these ever kind of situation, and this is just more information to help you make your decisions. Next, I want to talk about a new treatment that was just approved 2026. So this is a FDA approved at-home brain neuromodulation device for adults with treatment-resistant major depressive disorder. It's called ProLiv RX. That's a capital PR and then ROLIV and then a capital R lowercase x. ProLiv RX. All right. And what's cool about this is it's actually FDA approved, and it's a device. So typically devices are FDA cleared. Approval is a higher level of, um, you know, kind of that this is a good product. Like approval is like more evidence that this is something that we're okay with using. Cleared is a lower standard. We don't clear drugs though. Drugs have to be approved, but devices can be approved or cleared, and approval is kind of a higher level of approval. All right. So this is a new device, just got approved, and it provides electrical stimulation of the occipital and trigeminal nerves via a wearable headset. And so this thing kind of, I don't know, it looks like kind of like headphones, like, but like the part of the headphones that like go over the top of your head like is on your forehead. And so it looks kind of like a headband, um that's like, made out of plastic, and you put it kind of around your forehead like that, and it provides this electrical stimulation to these nerves. It's app guided at home treatment. It's approved as an adjunctive treatment, so that would be like in addition to antidepressants, and it's approved for those that have failed at least one medication. So that's not that much. So if someone's failed one medication, you can write them for this device, and they use it at home, and it's 2 40-minute sessions, at least 5 hours apart, and the effect size was pretty big, 0.8. Oftentimes these effect sizes can be higher when things first come out, because we only have like one or two studies, and they're studies done by the manufacturer. So as we get more studies, we find out things are less effective. There's also this attenuation effect, which is really interesting, of when something new comes out, it tends to actually work better initially, and it actually works less well the longer it's out, which is, I mean, it's some sort of weird, I think it's called an attenuation effect. It's some sort of weird placebo thing where I mean, that's I don't completely understand it, but I think it's more like, oh, this is like there's some sort of association with newer things working better, and so it's not even about like the studies and like, oh, it actually doesn't work as well as we thought it did. Like that's an effect, but there's also this effect of the longer something is in existence, even if you've never tried it, even if like the patient has never tried this before, just the fact that it's been out there, it's a weird effect. There was a story on Radiolab, which is a podcast that I like, where they talked about this effect, and it's just kind of like one of those weird phenomena that we don't completely understand. And so that's another reason why, I mean, use it now while its effect size is high, like before it gets attenuated. I don't know. um it's interesting. So it's a good effect size. uh Side effects are going to be very minimal. You're not putting any medication into your body. That may appeal to a lot of patients. So just came out. I'm not sure like how difficult it is to prescribe this or how much it costs or anything like that. But just to let you guys know, we do have this other device that's available now, and that it got the FDA approval versus clearance, which I don't know, to me kind of indicates that maybe it's better than some of these other new crazy things that might be coming out. So another option. And I mean, the other cool thing is it's not just for MDD, it's for treatment resistant MDD. We don't have many treatments. So if you go back to my episode where I talked about treatment resistant depression, we don't have a lot of approved things for that. This is now on the list, right? So our standard medications are not approved for treatment resistant depression. I mean, these are things like TMS, I think esketamine. Um, I'd have to. I think some of the antipsychotics maybe. I'd have to look at the list. Most of them are adjunctive, as this one, so you have to use it with the standard treatment, like a SSRI or something. I mean, you don't have to, but like that's how it was studied and how it's approved to be used. But it we now have another treatment resistant depression and an effect size of zero point 0.8. I mean, that's pretty great. And so I said you have to fail at least one medication, but in the studies people had failed, the people in the study had on average failed like more than one. I think it was like 2 to 3 or something. So um the patients that this was tried in had failed more than one. And I mean, people you're probably not going to give this to people who have only failed one treatment, but you can. All right. So, new treatment out there. I've got a few more studies to go through. Let's look at these. So, there is a new long acting injectable of olanzapine that may be on the horizon. It was just submitted for FDA approval. I think there's a really good chance it's going to get approved. I mean, we haven't talked about the antipsychotics yet either, but many of you may know we do have, was it Relprev? Is that how you say it? Which is it's something that we don't really use. It's got the black box warning. You've got to watch the patient for a couple hours after you give it. It can cause pretty serious side effects, so it's just not used a whole lot. That's the current olanzapine long acting injectable that's approved. Um, Olanzapine is a really good medication. It's probably the best medication next to clozapine that we have. And we always like to use a long acting injectable if we can. And so to have an alternative to Relprev that's a long acting injectable of olanzapine, I think is pretty awesome. So we'll be on the lookout for if this gets approved and what, is it going to have this black box warning? Is it going to have the risks? Is it going to be more effective? I don't know. We'll find out. All right, next. Um, I got a couple more ketogenic diet studies. It seems like every time I do an update, there's a new ketogenic diet study for depression that shows that it helps. And I've got a couple more here. So this first one is titled Ketogenic Diets and Depression and Anxiety, a systematic review and meta-analysis. All right. So this is, they're looking at it's a meta-analysis. So they're looking at lots of different studies that have already been done and pooling the data. And we've already seen that it looks like ketogenic diet is probably like effective for depression. It's probably effective for schizophrenia, to be honest. I'm seeing that as well. We haven't talked about that as much because I haven't talked about schizophrenia. But here we're looking at anxiety as well. I haven't really seen any studies on anxiety, so now we have one, and it's I guess that they're out there. So this is a meta-analysis looking at them, and not really surprised. The effect size for depression 0.48. That's kind of what I've seen in other studies, but like, now we have another one to kind of confirm that. And then for anxiety, um, only 0.03. So virtually no effect whatsoever. Like, it's not even a small effect. That's like no effect. So it looks like with what we currently know, ketogenic diet probably not effective for anxiety, but for depression, yeah, and that's 0.48. That beats pretty much any medication. So, but of course, there are caveats to this, and I'm going to talk about that in relation to the next study. All right. So, I just added this one here today. I just saw this one, a ketogenic diet for treatment resistant depression, a randomized clinical trial. So this one is cool. So this is the first of its kind where we're actually looking at a ketogenic diet with a really nicely designed randomized controlled trial, and not just looking at depression here, but specifically treatment resistant depression. So this is folks who have failed like a lot of other stuff. And the study, once again, this was an adjunctive treatment. So they looked at combinations. So they're on an antidepressant, which, I guess maybe helping a little bit, but not enough. And then we add a ketogenic diet on top of that. And we found an effect size at 6 weeks was at 0.68, and at 12 weeks, 0.58. So we've seen this before where the effect kind of becomes less with time, but still both of those are really good. And especially when we're looking at treatment resistant depression. So, this is already a disorder that like medications aren't really working for. And so to have an effect size this high, when I look at the actual data, they compared it to another diet they called the phyto diet, which to me sounds like a plant-based diet, but it was more like just decreased saturated fats and increase in vegetables and fruit. And so it was more kind of like a standard recommended healthy diet. Not that it wasn't a Mediterranean diet. It maybe resembled it, but they called it a phyto diet. And so they compared the keto diet versus that. So basically a diet with low carbs versus a healthy diet that has a normal amount of carbs in it. And the difference between the two was not massive. Like when you looked at the actual drop in numbers, it was only like maybe 2 or 3 points on a PHQ-9, but it still translated into like these fairly high effect sizes. So like, I'm like, okay, the effect sizes look really good, but still the drop in numbers wasn't that great. But then, I'm curious, like, what about compared to like a standard American diet? I mean, we know that. I talked about this a lot in the other studies, that like a Mediterranean diet or a healthy diet improves mood, and the number needed to treat of 4 is better than most medications. So even if the ketogenic diet is not that much more effective than a healthy diet like a Mediterranean diet, it still shows statistically that it improved mood even more than that diet. But the caveat here, once again, is the ability to, one of the biggest problems with the ketogenic diet. It has really two big problems. Two big problems. One, people can't keep it up. And that was the problem with this one. Even though these patients improved at the end of the time that they looked at, this 12 weeks, they asked people, is the ones that were on the ketogenic diet, or I think they may have even like done a crossover where they had tried both diets. But they said, would you want to continue the ketogenic diet? And most people said no, even though they had this improvement in symptoms. And so that's probably one of the biggest problems with the ketogenic diet. Like the biggest problem is that most people can't keep it up. They don't want to keep it up. And even people that like it, are they going to do this for the rest of their lives? You know, probably not. And so if they can't adhere to it, is it worth even considering? And then the other issue is the increase in saturated fat and the risk on heart disease with that. And it's like it it makes it even more. And I know people that follow this diet, they don't believe this, but it's true. Increases in saturated fat will worsen heart disease. um will it, if you went from a diet of highly processed carbs to one of higher saturated fat, your risk may not change much at all, or it may change a little bit. But if don't have excessive amounts of either of those things in your diet, you're going to lower your risk. So I don't know. If you were on a really crappy diet and you switched to ketogenic diet, your cardiovascular risk may not change much, because you're exchanging one thing that's not great for you, for your heart, heart disease, for something else that isn't. And if your mood improves and you lose weight, and you have other benefits, and your cardiovascular risk stays the same, then perhaps that's better for you. It would be better still to not have all this saturated fat. And so the problem is, because the ketogenic diet is so restrictive with such low carb intake, it leaves you with not a lot of foods left to choose from. And then you're left with a lot of stuff that's high in saturated fat, and you're left with processed meats, which can increase your risk for cancer. And so you really shouldn't be eating these things either. And so it's like, okay, well, I can't do the carbs, and then I need to avoid a lot of these things that are helping me adhere to the ketogenic diet, because those aren't really good for my health either. And then you're on a really, if you want to have the best cardiovascular outcome and get the benefits of the ketogenic diet, you're on an even more, you're on like an unprocessed foods, low saturated fat ketogenic diet, which is like even more restrictive, and so even more difficult to adhere to, right? And so for kids that have uncontrolled seizures that nothing else works, we know that this is a good idea, and it works for some people, but it's just too hard for a lot of others. And then of course you've got we're seeing improvements here with depression, and we know with schizophrenia as well, we're seeing signal for that. And it's like, if you can adhere to it, and schizophrenia is just so debilitating, and as well, treatment resistant depression, if it's severe, can be very debilitating as well. So you know I think if it's something you think you could do, it's worth trying, see how you feel. And if you're like, I like it and I think I can stick with it, then go for it. But it's unfortunately not a great option for most people. All right. So we're getting more and more information that this could be helpful, but we're also finding out more and more that like people just don't want to adhere to it, can't adhere to it. um, they're sneaking carbs that they don't realize. If you have to be in ketosis, you have to track this, and if you're not, you're just not getting the benefit. And so it's tough, but at the same time, more and more data that it's helpful for depression. All right. And then so the last thing I'm going to talk about is, so the state of Colorado, they have this natural medicine program where they're using like hallucinogenic type of medications, like stuff that is Schedule 1 controlled substances. Um, it's been permitting more and more of these to be used. And so in psilocybin, I think Oregon as well, don't quote me on that, but I believe Oregon as well allows the psilocybin. They have a similar program. But currently, psilocybin is the only hallucinogenic type of medication used in this natural medicine program in Colorado that's approved. But they've been looking at ibogaine and DMT and mescaline, and I actually I haven't talked about this yet, but like I have him. I checked my slides and it said, ruling to be made in 2026. It's 2026. So I just saw an article that ibogaine is one step closer. DMT and mescaline a little bit further down the chain. Ibogaine, we haven't talked about it yet, but it's a really kind of it's from an African plant. There's some issue of like how would we even get it into the country? It's not grown in America. So that I'm not sure how legally to get it in there. I'm not sure if you can grow it. It's the climate, etc. It's something that they use in, I know, Mexico and Brazil. There are some treatment facilities. It's used for substance abuse treatment. I've heard it can be quite effective. It can be risky. I believe QT prolongation is a risk, so have to be careful with it. But it's effective when a lot of other stuff isn't, and so I think we should definitely try and figure out like if how to if and how to use this. And so Colorado moving one step closer. So I think that's kind of some exciting information. But how they're going to get it, and it's still legal. It's still Schedule 1, and how do we parse that out? And on that note, cannabis, marijuana, has is actually like I know there's been some steps taken to remove it from Schedule 1 and move it into Schedule 3. I didn't add this into my slides because it hasn't actually happened yet, but it's moving in that direction. So I'm not sure like what all impacts that'll have. Like, if it's a Schedule 3 substance, that doesn't mean that you can sell it at dispensaries, right? That means that it's a prescribable drug. So it'll open the door for medicinal marijuana, but still like kind of like the dispensaries and like the edibles and this kind of like off the kind of off the normal market of use of it. It would still that wouldn't legitimize that anymore just because it was taken from Schedule 1 to Schedule 3. It's still it would still be a controlled substance. It would still not just require a prescription, but also would have to require the guidelines on how to prescribe a Schedule 3 controlled substance, which is higher regulations than substances that are prescribable substances that are not controlled substances, right? So um, certainly, that doesn't mean you can't be over the counter if you're a controlled substance, right? So we of course have medications that are over the counter, that are medications that can be prescribed but also can be over the counter. But if you're a controlled substance, that's not an option. And when you have these like dispensaries and things like that, I mean, a lot of you probably have been to these and seen these and seen, they're I mean this the market for this has just gone through the roof with we haven't talked about it, but like there's this backdoor they've gotten in with, like, if it's derived from hemp and not from cannabis, and it's actually the same plant, but the difference is how much THC it has in it. But then of course they take the hemp and they concentrate the THC and extract the THC from the hemp, which is legal, but they basically get the product that is similar to cannabis anyway by the way that they get the THC out of the hemp. And that's how they can legally get away with this. So I don't know. I mean, there's a lot of movement with this stuff. We had like ecstasy MDMA, which was they were looking at for approval. The FDA declined that. I think it was last year. So using that in treatment of like PTSD and things like that. But and of course, Colorado not technically allowed to use psilocybin and ibogaine, but the states just kind of are doing their own thing, kind of like with the medicinal marijuana uh, thing. So regardless, I mean, I think this is interesting information that this ibogaine is moved one step closer in the state of Colorado, and kind of opens this other discussion up about like how this whole market works. And I haven't really got into that because we haven't talked about substances yet. There's so many topics to cover. I'm I could go through them randomly, and I could do them what I think would be the most interesting topics all up front, and I get all this interest and kind of bounce around all over the place and talk about antipsychotics and lithium and all these cool things that I really want to get to. But then it would just be kind of, the other information later. And I'm taking the approach of we're going to tackle this one drug class at a time, and we're going to extensively learn all about how to use the ins and outs, the efficacies, the downsides, how to address things in a very organized manner. And this will just be available in the future. So if 5 years from now someone can go back and just go through that depression series and get all that information that they want, and then hopefully that makes it easier to kind of learn everything you need to know about one topic. And then I throw these updates in there to kind of say, hey, we've talked about some of these topics before, and this is some new information, and we haven't got to some of these topics before, but at the same time, I'll go ahead and throw in, you may know some of the stuff that I'm going to talk about when I get to this, but you probably don't know this new information. So kind of like headline news, this came out. So that's our February updates episode. I hope you enjoyed it, and I hope you'll stay tuned for next week's episode, and I will see you then.